Hello, good evening. I welcome all my viewers from Facebook, LinkedIn, as well as YouTube for today's live presentation. Today, I am going to talk on a very interesting topic. Many times, my patients ask us, Doctor, I have very low AMH. Can your immunological treatment, the ImmuLIT treatment, will be beneficial for us? What do you think? So let us discuss this important aspect and what is the correlation between the low AMH and the immunological treatment and whether it is really beneficial in with low AMH or in which conditions it will be can be given for a patient with low AMH. I am Dr. Mohan Raut. I am a clinical reproductive immunologist and gynecologist, and we have our centers, Dr. Raut Centers for Reproductive Immunology in different parts of India, and where we treat couples with unexplained repeated miscarriages, recurrent IVF failures, and unexplained infertility with our patented and branded process of ImmuLIT. And today we are discussing one aspect of this ImmuLIT treatment or indication for ImmuLIT treatment for couples with low AMH. Now, let's first understand what low AMH means. So, I am a clinical reproductive immunologist and gynecologist. We don't do IVF, but yes, low AMH is an indicator of the ovarian reserve, right? So, it just tells us about the number of follicles, or for that matter, immature oocytes that are left now in the ovary, and it is a measure of the of a measure of fertility, you can say, of the patient. And lower the AMH value, lower the number of eggs in the ovary, and there are lesser chances, or the fertility tends to go down. But here it is important to remember that AMH is not the only criteria to decide about the ovarian function. All of you are aware that apart from AMH, when we decide about the ovarian function, we have to see the hormones like FSH and LH, and also the important sonographic finding of antral follicle count. So these three things together, the FSH LH values, the for antral follicular count and AMH, will help us to know about the ovarian function. So just low AMH does not mean that patient is not able to conceive, and low AMH doesn't mean that patient will always require a change of egg or a donor egg. So this is about low AMH. So there's one very important thing here you should remember is low AMH doesn't mean the patient cannot become pregnant. Very important to remember, because even ASRM has said that uh, decrease or low AMH doesn't mean there is inability to conceive. And what ASRM specifically says that very low AMH cannot be an indicator or cannot be a reason for denying IVF to such patient. So therefore, yes, AMH, even if it is low, there is always a possibility for conception. Now, coming to ImmuLIT. Now, what is ImmuLIT? Now, ImmuLIT is our patented and branded process of active immunomodulation. And this is a treatment where we use lymphocytes from husband or a donor to induce certain immunological changes in the patient or in the woman, so that it helps to produce the protective antibodies or the asymmetric antibodies and increase the T regulatory cell count. And this is useful treatment for couples who have unexplained repeated miscarriages, recurrent IVF failures, or unexplained infertility, where immunological investigations indicate an alloimmune problem. So this is an immunological treatment. Now coming to the answer to the question that I mentioned at the beginning of the presentation, whether ImmuLIT will be useful for a patient or a woman with low AMH. The one line answer I would like to give here is ImmuLIT does not increase the AMH level, period. So ImmuLIT is not a treatment for patients who have low AMH. It will not increase AMH. The follicles what are remain in the ovary will remain, number will remain the same, or it will gradually decrease over years, and ImmuLIT has no role in increasing the AMH value. But but it is very important here to remember that low AMH and low AMH and the ImmuLIT take care of different aspects of the treatment, because low AMH and reproductive immunology address two parts of, you can say, reproduction. AMH deals with how many eggs are left or how many eggs will be available for treatment, say IVF treatment, while ImmuLIT will see that after the embryo is formed and after the embryo enters the uterine cavity, whether it will be accepted, how it can be accepted by the mother's immune system. So it acts at different stages, so therefore they are not interrelated. So this distinction is very important to understand, that AMH, the ImmuLIT doesn't have a direct role in increasing AMH. Then, what is the importance of ImmuLIT in a patient who has low AMH levels? So, here it is important to know that a patient who has low AMH, that doesn't mean that patient is having inability to conceive or conceives and miscarries because of low AMH only. She may have associated other condition responsible for reproductive failures, or for that matter miscarriages. So low AMH is not the only cause for reproductive failures. So here what I would like to suggest is, rather than focusing only on AMH value, it is important to focus on patients' reproductive history. So, reproductive history with low AMH is important. Whether this patient with low AMH has conceived and has miscarriages, or whether this patient has recurrent implantation failures with very good embryos or genetically tested embryos. So, there must be a reason other than just low AMH for the reproductive failures. And therefore, in such cases, we can separately do the testing for such patients to find out whether she has an immunological problem which is responsible for reproductive failure, and if so, then we can accordingly give ImmuLIT treatment for such patient even with low AMH. So again, it is important to remember that, just confirm that a low AMH is not is it the only problem responsible, or there is another independent problem. So uh, so finally, I think what I would like to say here is, immunity is not a standard of care, you can say, for low AMH. And my take home message here will be, don't treat AMH report, I would say, but you treat the patient. AMH report will just tell you about the ovarian reserve, while when you treat the patient, you find out whether there is any associated cause responsible for patients either implantation failures or having miscarriages after the IVF for a patient with very low AMH. So here I would like to end with one important suggestion to the or important answer to this initial question is, whenever someone asks about low AMH, explain to the patient that that is not the only cause for not conceiving, and it is very important to rule out other factors, and if immunological factors are there, then ImmuLIT can play an important role. So these two are distinct areas, and therefore a patient who has low AMH will be benefited by ImmuLIT treatment, not to increase the AMH, but take care by taking care of the associated immunological problem. I think this will make it clear whether whether there is any doubt about whether ImmuLIT can be given, or for that matter, immunological treatment will increase the. I think there are. Let us see. I think there is one comment. I think very good explanation, sir. Thank you taking time to explain everything so clearly. I have one question about ImmuLIT, not related to AMH. So I think. If there is any question, I would like to, yes, you can go ahead, Janvi. I think if there is any question, could you explain how HLA matching and CDC cross match differ? Are they independent tests, and or are they related? Very important question. I think this every day in our consulting room we have been we come across these tests and the reports. So HLA matching. So, I don't know whether Janvi means HLA typing or HLA matching, because there is a test which is very commonly done, and that is HLA typing, which is a genetic test which tells us about the HLA alleles, right? And alleles, whether there is sharing of these HLA alleles between husband and wife, and whether they more about HLA-C. So that is a test that tells us genetically which alleles are present, and whether there is with certain association between genetic testing and reproductive failures. For example, if there is sharing of certain alleles between husband and wife, there are more chances of reproductive failures. Then, so the second thing is the HLA-C and KR genotype, the association between these two. And if there is particular type of HLA-C and particular type of KR genotype, like suppose KR genotype and presence of C2, especially paternal, into the possibility in the embryo, then there are more chances of reproductive failure. But these are genetic tests. They will tell the possibility. There's possible chances of reproductive failures are more, and therefore they just predict that there are more chances, because genes don't directly act themselves. They act through certain mechanisms like antigen antibody reaction, or through cytokines, or through immune cells. So that's what is important to test, so that you can give immunotherapy. Okay, see, if you are not treating the patient immunologically, then you can just rely on genetic testing and predict the outcome. But if you want to treat the genetic immunological problem, we require immunological tests. So the CDC cross match. Now, CDC cross match is with husband and wife's blood, and it helps to detect the anti-paternal antibodies which are protective in nature. So these are antibodies which protect the pregnancy and which are important for the immunological treatment. So these protective antibodies can protect any pregnancy, whether it is from self gametes or by donor gametes. So HLA typing, if you are mentioning, then they are different tests, and their purpose is also different. See, HLA cross match, more advanced HLA cross match is required even for transplant with different interpretation. And I think there is one more question you have asked, Janvi. Is the LIT protocol modified based on these test results, or is it standardized treatment regardless of whether the issue is HLA related or CDC cross match related? So there is no separate HLA related issue or cross match related issue. So if the protective antibodies are not there, then uh, the LIT protocol will be beneficial and will be required. And if the husband is not able to give blood, and if the for some reason is not fit to give blood, then a donor can be used, where the who is tested for infection profile to produce the immunological changes. So this is an immunological treatment, not a genetic treatment. And so the protocol, the method of doing LIT, the not LIT the way we do it, it's the ImmuLIT procedure, which is a one-time procedure, is not based on, once the diagnosis is done, the ImmuLIT procedure is planned accordingly. And what is the LIT protocol? No, so I think it's the same question. So, because uh, ImmuLIT is one part of our treatment of the entire protocol. This is which is followed by certain immunomodulatory medications depending on the immunological test reports, which completely forms the treatment. So, which is helpful in producing the immunomodulation. So, I think that should suffice. If there are any detail you want, you can always contact us, Dr. Janvi, and we will be happy to discuss this topic in detail. And so I think this is about use of LIT, use of ImmuLIT, and the patients of low AMH. So there are similar questions which we face every time. So I will, in my subsequent live presentations, I would like to address all these issues also, where the it's where the information is otherwise not available in the literature, but with our uh, experience of last 30 years, we whatever we have learned over these many years, we can share here with everyone. I think Janavi has mentioned it is about HLA typing. So HLA typing, as I mentioned, is a genetic test. Okay, and while we uh, look into the immunological part, and that for that will require immunological test to plan the treatment. Because with genetic testing, what will be recommended is either you change the gamete, and then, or you don't plan pregnancy, it is not possible, so you undergo surrogacy. So this is if you don't use immunotherapy. So therefore I feel that to plan immunotherapy, we require immunological investigations which deal with cytokines, antigen antibodies, and immune cells. Okay, so thank you very much for your participation, doctors, and I'm thankful for certain comments, thanking to be very informative. So I think that encourages us to keep on doing these live presentations, and I'm thankful to my wife, Dr. Mugdha, also. I think she has been traveling, but I think she has joined from, I think from the flight she has, with the Wi-Fi she has joined. So thank you so much. She's on her way to the US, and without her support, it is not possible for me or for us to be where we are now. And any other questions? If I'll just check. Thank you, Janvi, for your encouraging remark. So I think I will stop here, and thank you so much again for present here on this live presentation. Have a good night, and I think for my viewers outside India, maybe outside accordingly, maybe good morning or good afternoon.